Thank you very much. I'm sorry not to be there. I'd love to have been there. I absolutely love Bristol and Bristol colleagues, and Nick Timpson is a legend in my humble opinion, and Laura and the colleagues. So obesity is the biggest challenge in health. I think it probably is one of the biggest modifiable challenges. Let me say. I mean, there are other challenges which we can't really change. Here are my disclosures as well as my healthcare goals, and I'm working with lots of trials with lots of industry, but I've also done lots of lifestyle trials, including the direct trial, as well as trials of lifestyle in pregnancy and in South Asian. So I really have covered the landscape really in this area. I have no shares in any companies. I want to start off with this. I guess I wrote this for the Lancet Diabetes because I think there's been a lot of misconception. Is that if you think about before the 1970s, even before young Nick was born, certainly when I was born, the average percentage of obesity was about 5% in the UK. In the 1950s, it was 2%. Now we're at beyond 30% in some places. And there's also a bigger social class gradient, and that's growing as well. And the things that have changed are not our genes, and Nick and I had this conversation by email, our genes, and we're not any lazier or greedier than previous generations. The things that have changed is really the environment. It's the food environment, activity environment, in a way that is substantial. And I don't think it's getting any better. I think actually it's getting worse. And I think that's a big challenge for many of you who work in this landscape. And it's not really anyone's fault. I think it's just the reality of the changing in food environment and the economy and the various other aspects linked to that. But we do need to tackle this because we cannot just treat obesity just with medications, which appear to be good. And I'll tell you a bit about them. But so many kids are being brought up with obesity, and obesity is going up fastest in the young people because if you think about it, young people are born nowadays in an environment which is much more obesogenic than many of us were born in, and that's a reality. So it's a tragic reality. The other reality is that because we're keeping people alive a lot longer, and I wrote this paper in 2022, and the title is really hard hitting: treating chronic diseases without tackling excess adiposity promotes multimorbidity. By that I mean is that it's no longer good enough just to treat hypertension or the fourth generation cancer drug or whatever if you don't tackle also the obesity. If you look at the red line, 25 years ago, somebody might have developed Mr. Smith heart failure. He either died prematurely for cardiovascular disease or cachexia because of his heart failure at the age of 65. Nowadays, and he had an MI prematurely because he smoked. Nowadays, with less smoking, more statins, more blood pressure, less LDL, less saturated fats, less salt, people are not developing heart attacks sooner, they're developing later. They're not dying with heart failure because we have disease-modifying drugs, but we're not tackling the obesity. But because obesity has been going up and up, Mr. Smith has been putting on weight faster, living longer with his heart failure to develop. And because he's got many more years of obesity, because of that, he's then developing his secondary metabolic complication, diabetes, his secondary hemodynamic complication, kidney disease. He might also have osteoarthritis, activities of daily living issues, and therefore he has long-term multiple conditions. And if you go to our wards in the Royal Infirmary, it is full of people between 60 and 90 who are much heavier than they ever were in the past. Just a reality. It's good that they're living longer, but the bad side of it is they're living longer with obesity, and they're on about 15 to 20 tablets with 5 or 6 or 7 or 8 conditions. And many of them, half of them probably are linked back to obesity. And that's a reality. And it's a reality we cannot keep going forward with. The good news is, of course, I don't really want there to be lots of tablets that we need to use, but the reality is, we do need medications because if the environment isn't going to change quickly, and it's certainly not going to revert back to the 1970s anytime soon, we have medications now that actually help big weight loss, up to 15 to 25% weight loss. There are tablets coming which were presented in the New England Journal yesterday, and probably in the orforglipron. And with big weight loss, you can actually improve multiple conditions. People feel better. They look better generally within themselves. They have the reduction in food noise. They have less fatigue. They're generally happier, and they have less comorbidities. Some of the comorbidities improve substantially. Some are prevented substantially. And in addition, the class of drugs that we're now using also seem to have direct effects on the heart and the kidneys and diabetes as well, in the way that we perhaps didn't anticipate. And here are some of the quick data. And I've only got this is the last but one slide, just because I know time. If there is time, if you want 2 or 3 questions, I'm happy to take them. But big improvements in heart failure in the way that we didn't expect, and it's now in guidelines. This improvement in KCCQ is more than double what we see with the SGLT2 inhibitors, which are now foundational and the best other therapies in heart failure. A 50% almost improvement in sleep apnea, so half the patients didn't need their CPAP. Big improvements in kidney outcomes, delaying type 2 diabetes, and I want you to recognize this with tirzepatide or Mounjaro, as you might know about, by 94%. By 94% delaying of type 2 diabetes over the course of 3 years. That just, if you think about that, that tells you that type 2 diabetes is a disease of excess ectopic fat by and large. Plus, of course, the drug has an incretin effect. And a third reduction in knee pain. So you can't remove knee pain completely because some of that knee pain is actually because of diseased joints. What you can do is reduce the pressure on those joints by reducing the level of adiposity. So there's a mechanical effect, metabolic, hemodynamic, i.e. reducing your amount of fluid and volume pressure on your pumps and your pipes and your filters like your kidney or your pumps like your heart. And there's also a mechanical also improvement. So multiple effects of these drugs. And we've just reported a paper today that will come out in a reputable big journal that there was a reduction in mortality by by about 16% relative to another drug, and if you compare it to placebo, by over 20%. So these drugs and lowering weight intentionally has major benefits. So final reflections, there are massive changes. We've been slow to interpret the obesity epidemic in a way that is completely unprecedented in terms of health. Weight is a major modifiable driver of many long-term multiple conditions, more than you ever imagined. It's either a driver or an accelerator, even if you've got a condition. Weight loss medicines help many withstand the environment. That's how they work. They kind of reduce your appetite and give you less food cravings. Most of the gains of these drugs are due to big weight loss, but they also have direct effects on various tissues, and we're seeing really great effects. But they can't cure everything. They're not going to revert you back to normal if you've already got diseased joints or a scarred heart or a scarred liver. They won't normalize things, but they can certainly prevent future and slow further declines. The safety profile is generally good. The GI side effects are definitely there, but can be mitigated by starting low and going slow. And there are hundreds of drugs in development. I'm involved in 5 or 6 randomized trials beyond Wegovy and Mounjaro or semaglutide and tirzepatide. And many of them are just as potent potentially, and many of them, and hopefully this competition and the prices will come down. And actually, public health shouldn't be worried about them. We need them. We can't not need them, but they might actually help us improve the food environment. So rather than thinking it's them or us, no, it's both. We have to prevent and we have to treat. It's not one or the other. And maybe the drugs, by cutting food noise in people who are living with obesity, and people with obesity then go out less to buy fast foods and other things, maybe that will help provide a capitalize or a spark to help improve the food environment in the way that really works. Although I still think it's a tough ask, because food companies and drinks companies are a big part of our economy, unfortunately. And dietitians shouldn't be worried about them, because for the first time, some patients might actually be able to adopt by changing the diet because they have less food noise for the cravings that they usually have. And those are the kind of things. So prevention has to be a must, has to be for our kids, but also you have to think about treatment. The issue, of course, the drugs are expensive, and how long do you need to use them for? Those are the kind of issues that we're dealing with as part of the work that I'm involved in, and we're generating a lot more evidence. So that's my starter for 10. I wish you a brilliant day going forward. If you do want to have a couple of questions, I'm happy to take them if you've got time. If not, thank you for listening, and I hope you have a really brilliant day, and I will look forward to coming down and spending more time with all of you in the future. Thank you.